Hello and welcome. My name is Kristen Talbot. I am the program manager for MAVEN Project. Thank you all for joining us today, and our friends at Community Health Center of Cape Cod for hosting today's session, Appropriate Use of Laboratory Testing in Surgical Patients with Dr. Robert Lohr. Dr. Lohr practiced general intern medicine at the Mayo Clinic in Minnesota since 1993. In recent years, primarily perioperative medicine. He's staffed the Mayo Preoperative Evaluation Clinic and the Internal Medicine Consult Service, which focus on perioperative medicine. And we are just very lucky to have Dr. Lohr as one of our MAVEN Project volunteers. So Dr. Lohr, when you're ready, please begin.
All right. Thank you very much, Kristen, and welcome everybody. I appreciate the opportunity to spend a few minutes with you. It's a little bit earlier here than where you are, so I have my cup of coffee with me, and I hope you had a chance to have a little coffee and breakfast this morning too. We're going to talk about something that I know you encounter virtually every week. So this is going to hopefully create a framework for you to do a proper and complete preoperative evaluation. Now things aren't advancing here. Okay. Don't have any disclosures to say. This is accredited as Kristen described. The only thing I do want to disclose, and actually she covered this, is that I'm presenting this from the standpoint and from the viewpoint of a general internist. I'm not an anesthesiologist, I'm not a cardiologist, but as Kristen mentioned, I spent a lot of time in a preoperative evaluation clinic working with anesthesiology actually, and staffing a consultation service in the hospital, which focused on perioperative medicine primarily. Our objectives today are to define and apply the rationale for evidence-based preoperative testing in the context of high-value care, and importantly, for the average risk patient. We'll talk about situations where patients are not average risk and may need more testing and evaluation. And in a couple of weeks, we're going to be talking primarily about the cardiovascular aspect of that. So we'll try to define when preoperative testing is not indicated and when it is. We'll go through a little bit of background first, then I have some cases to illustrate a couple of points, and then we'll spend a little time discussing individual tests and the rationale for doing them and when you don't need to do them. And there will be time for questions at the end, I'm sure, which I hope you have. Now, I don't put this slide up for you to read it, it's too small, but I do want to point out that this is not a new problem. This was published in JAMA in 1985, so probably before some of you were born even. And even back then, and this was a retrospective study, they looked at all the pre-op testing done on 2,000 patients. And the conclusion was that 60% of the routinely ordered tests, so these were tests that everybody got no matter what, would not have been done if they had been done for a recognizable indication. And 0.22%, less than 1% of these revealed any abnormalities, and a smaller group required any action. So this has gone on for a long time. How are we doing now? Well, this is a 2021 study in JAMA Internal Medicine, again, retrospective. In this group, 50% of patients received at least one needless preoperative test. The other major conclusion was that hospitals and surgery centers and medical groups really lack protocols to de-implement or revise testing protocols, which are often embedded in preoperative order sets, as you know. I keep trying to advance this with the button and it won't work. So this is a problem. It's a costly one. This is just urinalysis, pretty inexpensive test, but we order a lot of them. And this is old data. This is probably double that now. It exposes patients to needless blood work and to procedures. It, of course, can create some anxiety for patients. Surgeons tend to order more than anesthesiologists, who tend to order more than preoperative clinic directors. and it requires follow-up of the abnormalities that are uncovered. And we'll talk about this, especially with chest x-rays in a little bit. This is an interesting study that I want to walk you through. It's from 2015. A group of hospitalists who all do perioperative medicine were divided into actually 4 groups. They were given the same vignette, which was an elective gallbladder removal, cholecystectomy, in a patient with a history of coronary artery disease, a good functional capacity. And as we'll talk about, that's a very important aspect of their cardiovascular evaluation. If the patient does have a good functional capacity, then a lot of cardiac evaluation is often not needed. So the groups were divided up so that Group A had, or the group was divided up, I should say. Group A had no information about the patient's son. Group B had the son identified as a physician. Group C, the son wasn't identified as a physician, but was asking for more testing. And in Group D, the son was identified as a physician and asking for more testing. So in the vignette, the choices given the hospitalists were to do nothing, a cardiology consult, some stress testing, a cardiac cath, or an echo. Now, the ACC-AHA guidelines, this is American College of Cardiology, American Heart Association, were used as a benchmark. And this study was done in 2015, and the guidelines came out in 2014. So they were quite current then. And as we'll talk about, they're not as current now. The results were, I should add that the guidelines would suggest that in this particular gentleman, and given these choices, you would do no testing. I would argue that you might want to do an EKG, particularly if you didn't have a current one. But nevertheless, that wasn't an option. So the best choice, the best answer would be nothing. So when the son was identified as a physician and not requesting any testing, there was still over half overuse. If the son was identified or not, but was requesting testing, 57%. And if the son was identified as a physician and requesting, it went up to 65%. So they asked the hospitalists, why did you overtest? Over a third said they were following the guidelines, which is a teachable moment. And we'll go through this today a little bit. And almost 2/3 said they just wanted to reassure the patient and the family and reassure themselves. But I would argue that doing tests that aren't needed isn't going to reassure really anyone. So there may be a lack of awareness of the guidelines or a misunderstanding of them. Again, we want to be assured, and we want to make sure our patients and families are comfortable. So we want to do that. There may be a concern about medical liability. There can be concern about negative feedback on patient satisfaction surveys. We're all subject to those now. And as you know, if there are repeated issues, you get a knock on the door from your boss or your medical director, and they say, let's talk about this. So that can be an issue. And we all also don't have time to do the explanation of why the test isn't needed, which can be a lengthy discussion. And even if we do it, the patient may be unhappy. So why should we test? Why do we need to do some tests? We want to identify or verify a condition which could affect the patient's anesthetic care. You are performing a consultation when you're doing a pre-op exam, and the audience is the patient, of course, the surgeon, and probably most importantly, the anesthesia team. You are not clearing the patient for surgery, even though almost all the time the request is, please clear Mr. Jones for whatever's coming up. The only person that really decides whether or not to put the patient to sleep and do the procedure or use the spinal or whatever they're going to do is the anesthesia team. So your job is not to clear them. And when you say they're cleared, it frankly puts you in some liability. If something does go wrong, and as you know, from your experience, no matter, the best of intentions and the best of circumstances, things can still go wrong. And if you have cleared them, you may, again, open yourself up to some liability. So your job is to do a consultation and identify those conditions which might cause problems and try to mitigate them as much as you can, or at least alert the team who is going to be taking care of the patient in the operating room and after they leave the operating room that these conditions exist. You want to help formulate and modify the anesthetic plan of care. Now, as you go through this, you need to consider these areas. Cardiac evaluation is a lot of this because cardiac complications can be very serious, as you know. We're going to spend an entire talk on that in a couple of weeks, so we won't dwell on too much of it today. But it does deserve some attention, and there are guidelines that can help us. Pulmonary complications are actually the most common ones that you might encounter, that a patient might encounter. They aren't always terribly serious, but they can be. And you do have to address the patient's pulmonary status, and we'll talk a little about that as well. The patient's often on medicines. You need to tell them if they should take them or not the day of surgery. And if you do hold things, you need to make sure that the anesthesia team knows that so that things can be restarted after the surgery. And this includes, of course, over-the-counter drugs. If the patient has a bleeding or clotting problem, or they're anticoagulated, particularly with warfarin, do they need bridging? You have to identify that, and we'll talk a bit about it. If they are on an anticoagulant, your advice needs to be, first of all, do they need to stop it at all for the procedure? Sometimes you do, sometimes you don't. Secondly, if you are stopping it, when, and then when to restart, and so forth. Many patients are diabetic. They need advice on what to do the day of surgery. Do I take my insulin? Do I take my metformin or whatever I'm doing? And what happens after the surgery? So we'll spend some time on that as well. And then finally, there are other conditions that may have significant impact on the patient's operative course. If they have severe liver disease, and I'm talking about cirrhosis here, cirrhosis with a history of ascites, encephalopathy, clotting problems and the like, not just an isolated AST elevation. If they have kidney failure or just renal insufficiency, chronic kidney disease, this can affect what medicines are used and may require medicine dosage adjustment. And lastly, endocrine, and this is not diabetes, but rather other endocrine abnormalities that can affect anesthetic care. The two ones that are most common anyway would be hyperthyroidism, overactive thyroid, and adrenal insufficiency. So those things need to be considered. Now, your patient may not have all of these things, hopefully they don't, but you need to be thinking about these as you formulate your consultation note. Well, how do you decide how your last case was, which wasn't well? So you're going to order everything in the book, what I was told to do in training, evidence-based medicine and guidelines, but which ones? And then there's the ever-present hospital policies and order sets, and when were they revised last, and who did the development of them? So what do the guidelines say? And I've just given you a sample here, and we're going to go through some of the recommendations in more detail. The American Society of Hematology says no pre-op coags unless there's a personal or family history of bleeding, which means you have to ask about that. The American Society of Anesthesiology says no baseline labs, including CBC, metabolic panel, and coags without a significant systemic disease underlying or its low-risk surgery. The Society of General Internal Medicine says no pre-op testing for low-risk surgeries. The American College of Surgeons, the American College of Physicians, and the American College of Radiology say no chest x-rays unless there is something on the physical exam. And importantly, because I know you get asked to see a lot of patients for cataract surgery, and they're all elderly, and they all have underlying conditions, the American Academy of Ophthalmology says no pre-op testing for eye surgery unless targeted by specific conditions. Now they have hedged on this a little bit. In reality, there probably is little indication to do any testing for a cataract, and we'll mention that later. So let's go through a couple of cases. The first one, you're asked to see a 43-year-old male for a preoperative medical evaluation. He's scheduled for an inguinal hernia repair next week. Past medical history is notable only for some obesity. He's a little bit heavier than he should be. And he had an uncomplicated ORIF, that's open reduction internal fixation of a tib-fib fracture when he was a teenager. So really pretty unremarkable past history. He doesn't use tobacco and he drinks very little alcohol. He does construction work and he can easily exceed 4 METs of activity. Now this, when I say someone has a good functional capacity, that's what this means. They can exceed 4 METs, which is climbing a flight of stairs, walking at about 1.2 miles per hour on a sustained basis, on level ground, that sort of thing. Anything over 4 METs, for example, playing basketball would be 10 METs, that sort of thing would be more than adequate. And when we talk about the cardiovascular evaluation, we'll talk about how to more precisely define, METs, and there are some tools that could be used for that. He takes only a men's multivitamin, and the exam, other than his weight and the hernia, is unremarkable. So what would you suggest for this person? A cardiogram and CBC, a cardiogram and a creatinine, a CBC and creatinine, CBC and an INR, or nothing. And I'll let you think for just a second. I hope you said nothing because that's what he needs. He does not need an ECG. He has no underlying heart disease and has a good functional capacity. We don't have any history of any bleeding problems. This is not going to be a particularly bloody operation. He's a fairly young man. We have no reason to believe his kidney function is not normal. And again, there's no reason to do the INR. So this man can go right ahead with your blessing and should do fine. Next is a 78-year-old female who is going to have a right total knee arthroplasty tomorrow. Her past history is a little more significant. Noteworthy for hypertension, hyperlipidemia, obesity, degenerative arthritis, and coronary artery disease, for which she is getting she has, I should say, 2 drug-eluting stents, and they were placed several years ago. So she's on single antiplatelet therapy at this time. She had a hysterectomy and carpal tunnel repair in the past without complication. She's on lisinopril and hydrochlorothiazide for her blood pressure, simvastatin for her lipids, metoprolol for her underlying coronary artery disease, and the platelet drug is aspirin. As you may know, clopidogrel is felt to now be the better single agent, but she is on aspirin. She's limited in her activity due to her knee, but really has been able in the recent past to do over 4 METs. So we're fairly comfortable that she has a decent functional capacity. Her exam reveals a little bit borderline blood pressure. It's a little higher than we'd like. She also is heavier than she should be with a BMI of 37. She had an effusion in her right knee, but her heart and lung exams are normal. You have an ECG, which is pretty non-specific, and it's 3 months ago, and it is stable. So it's not yesterday, but a relatively recent tracing. And you have no other lab data. So what would you like to do for this patient? Repeat her ECG and check electrolytes and creatinine. Just do the electrolytes and creatinine, the ECG, the electrolytes, creatinine, and an INR. The same things plus a dobutamine stress echo, or nothing. And again, I'll give you a second or two, and that's about it, to think about this. So she needs just the electrolytes and the creatinine. She doesn't need the ECG, even though she has a significant history of heart problems, because you have one that's relatively recent, 3 months. Our group actually will go up to a year. The key here is to make sure that the patient is clinically stable. If they are, there's been no clinical change in their exercise tolerance and so forth, you can use the old tracing. You don't have to repeat it. Now, if there has been a change, obviously you do need to repeat it, and you may need to do some additional testing as well. She doesn't need an INR, although this operation can have a significant blood loss. She has no clotting history and had previous surgery without complications. You don't need a dobutamine stress echo because we feel her functional capacity is adequate, but you do need some testing. So we would do the electrolytes and the creatinine primarily because of her medicines, the lisinopril and the hydrochlorothiazide. In addition, she is old enough that you want to know her renal function ahead of time. And I didn't list it as a choice here, but you might consider adding a CBC. And the reason is that, as I mentioned, this can be a kind of a bloody operation. And a 78-year-old with underlying angina, you don't want to have, you would want to know what the creatinine is ahead of time. Okay, our third case, a 58-year-old male for a preoperative evaluation. He's going to have a right TSA. Now, he's not going to the airport to fly anywhere. This is a total shoulder arthroplasty next week. His past medical history is significant for hepatitis C, but there is no history of cirrhosis, and he has no stigmata of cirrhosis. He had an inguinal hernia repair as a child without complication, and really has had no recent follow-up for his liver, and that means not within years. Pardon me. Medications include a multivitamin. He has good functional capacity, and except for his shoulder, his physical exam was normal. So importantly, no jaundice, no ascites, no petechiae, nothing to suggest any decompensation of his liver. So what would we want for this gentleman? A cardiogram, electrolytes, and creatinine. Electrolytes, liver function tests, and creatinine. Liver function tests, an INR, a creatinine, and a sodium. Coags only or no studies. So in this case, we're worried about his liver. Not that he has any overt stigmata problems, but we don't know the condition of his liver. And so it does need to be evaluated a little bit. And the combination of things that you need to order in order to assess that are the liver function tests, specifically his total bilirubin, the INR, the creatinine, and the sodium. And the reason for that combination of tests is that those are the elements that you need to put into your phone or your computer so that it can calculate a MELD score. And the MELD is the model for end-stage liver disease, which was developed for patients who are going to have liver transplants. But it actually correlates, it has been shown to correlate very well with postoperative morbidity and mortality. So if you do the MELD score, and the score ranges from a low of 6 to a maximum of 40, if you do the MELD score, and when I say you do it, it means your computer is going to do it because it's a pretty complicated computation, but you just plug in the numbers. If the MELD is 10 or less, the patient, generally speaking, will do okay. Now, it's going to be important that you mention this in your notes so that anesthesia knows, but they should do fine. If it's 10 to 15 or 11 to 15, I should say, there may be some concern. The patient is at risk. And when I say at risk, if you look at the operative mortality within 30 days of somebody with a MELD score of 15, it's about 40 to 50%. It's a very high mortality rate. So you need to be very certain that this patient is as compensated as they can be, and it may mean they need to see a gastroenterologist prior to the surgery. Now, if it is over 15, the MELD score, they should not proceed to the OR for an elective procedure until they're seen by a gastroenterologist, and maybe they shouldn't proceed at all if it's a truly elective procedure. And the reason is that that mortality rate goes so high that it really precludes doing elective procedures. Now, sometimes you have to operate on patients like that. They fall and break their hip, and I find them the most difficult patients to manage postoperatively. Everything that can go wrong with their liver does. They become encephalopathic from the pain meds. They develop ascites. They have a coagulopathy, and they often go into renal failure. So they're very hard to manage, and you have to be very careful about it. Okay, last of our cases You're doing a pre-op exam on a 22-year-old female, college basketball point guard, and she tore her left ACL, which is a common injury for young women who play basketball. She reports herself in excellent health, no prior surgery. She says her menstrual cycle is a little irregular, and she feels that's secondary to her physical activity. She takes no medicines, and her exam is normal except for her left knee. So what should she get? CBC, cardiogram, coags, pregnancy testing, or nothing rather. And she should have a pregnancy test. Her periods are irregular, and you'd want to make sure that she was not pregnant. We'll talk about that in more detail about why you would want to know that, or why, frankly, she would want to know it. So should we test? Routine, that means everybody gets a test, no matter what the operation is, what their condition is, should be dictated by the patient's clinical condition and abnormal findings on history and exam. It is not indicated unless there's a specific reason to perform it, and it will change management or mitigate some perioperative risk. So let's talk about a few specific tests. ECGs, we don't have really much prospective data to go on. There are retrospective reviews and so forth. There are somewhat conflicting consensus statements, primarily about when the age of the patient and when you do the EKGs. It is, however, the EKG is, however, used in some risk assessment guidelines in order to stratify risk. So there are reasons to do it. It's also, and this is an old, very old study, but it's still accurate, I think. It's true that patients who have abnormal ECGs have more problems, and 75% of people over 75, the age of 75, have an abnormal ECG. But if you look at the absolute risk reduction in this particular study, it was quite low, and this was for low and intermediate surgeries. So what do the current guidelines say? And I'll pause here and say the current guidelines from the ACC and AHA are 10 years old. And they are coming out with new ones, and I'm told that they're actually in press. And I actually looked yesterday to make sure that they hadn't come out, because I would potentially have to do some revisions to this talk and the next one as well. But they have not yet come out. So this is what we have. I don't think that their recommendations about doing ECGs is going to change too much. I think there may be some changes, but it'll be more about when you need to do stress testing and what alternatives there may be to do stress testing. So they said in 2014, and I think this will continue going forward, that preoperative ECG is reasonable. So they're hedging a bit here for patients with known coronary artery disease, significant arrhythmias, peripheral arterial disease, stroke, or TIA, or other structural heart abnormalities, unless the patient's undergoing low-risk surgery. And I referred to low-risk surgery several times, and I need to perhaps define it. Dermatologic, dental, most outpatient procedures, breast surgery, unless it is a massive reconstruction or a radical mastectomy, would be considered minor surgeries. They say consider for asymptomatic patients with known coronary artery disease, again, except low-risk surgery. So again, this is the situation where if you didn't have a fairly recent ECG and this patient has known coronary artery disease, then you should get an ECG. It's not useful for asymptomatic patients with low-risk procedures. So symptoms and signs, definitely. You know, whether they're high risk, low risk, if they're having some troubles, you need to document what's going on. Known disease, again, you can use an old tracing up to a year if you're very confident they've been clinically stable. And then if there are risk factors and it's higher risk surgery, so the RCRI is the Revised Cardiac Risk Index, and we'll talk about that in some detail in a couple of weeks, but it is a very widely used tool for cardiac risk assessment. It has some problems. It was validated and developed in about 1999, and at that time, proponents and things were not around. And so the very low RCRI scores, so 1 or less, are a little suspect. And you would probably need to use another tool. And we'll, again, talk about that more. If it's more than 1, then you're probably on pretty solid ground that the patient is at higher risk. If there's a CAD equivalent, usually that's diabetes. It's noteworthy, whoopsie daisy. Can't quite see the bottom of this slide on my screen. I hope you can. But the Canadian guidelines, which are newer, 2017, 2018, suggest a BNP if there's known cardiac disease rather than ECGs and stress testing. So low risk surgery, low risk patient, cataract surgery, don't need an ECG. A cataract operation is a 20-minute outpatient procedure done with local anesthetic. And so you, despite what many of your ophthalmology colleagues will say, you really don't need an ECG or really any pre-op labs. Maybe doing an ECG again, low risk patient with higher risk surgery or risk factors and low risk surgery. What about coag studies? Now, you saw what the American Society of Hematology says about this, that it's really only indicated by the history and physical. Now, if you think about it, what patients are at the highest risk if there is bleeding? And it's the neurosurgical patients, those that have had craniotomies or spine surgery. So I went to the neurosurgical literature, and yes, there is a little bit in it. It's not terribly recent, but I think it still holds. And in this study, the neurosurgeon said the patient's history was as predictive as lab testing for all outcomes and had higher sensitivity. So if there is a known bleeding disorder or previous bleeding complications, which means you have to ask about that when you're doing your pre-op exam. Certainly if they're on anticoagulation, that is a whole additional area to address. Or if their exam and physical suggests that they've had bleeding or coagulation problems. So patients have had, DVTs, they've had bleeding problems, you need to ask about it. How about the CBC? Again, if there are findings suggestive of an abnormality, you should do a CBC. Certainly, if there's a known cytopenia, recent chemotherapy, history of bleeding, if they look anemic, if they have pallor. I think more, these things happen, but more commonly, you would do the CBC if the patient is going for a procedure with a large, anticipated large blood loss, and a situation where even some mild anemia could be significant. So we could go back to our lady in the second case, I think, who is going to have the knee arthroplasty. That can become a pretty bloody operation. We know she has underlying heart disease. You might want to do a CBC so that the anesthesiologist knows, well, we're going into this with a hemoglobin of 14, should be okay. Or we're going into this with a hemoglobin of 10.5 or 11, I need to have blood available because we may lose 2 or 3 units of blood. So it's really to advise the anesthesiologist of how to prepare to take care of the patient. What about electrolytes and creatinine? Well, if patients are on diuretics, we want to make sure that they're not hyponatremic or hypokalemic. If they have known renal insufficiency, if they are on digoxin, to make sure the potassium is not low. I would, and I do do this, I would do a creatinine for pretty much all elderly patients. We know that renal function declines as we get older. And we also know that these patients are going to be given medicines that they are not usually taking in the perioperative period that need normal renal clearance if we're going to use them, or dosage adjustment if we're going to use them. And I think the best example of that is low molecular weight heparin. Most patients, if they're having inpatient procedures at least, will have DVT prophylaxis post-op, and that is a renally cleared drug. So I would consider a creatinine for most of the elderly patients. What about a chest x-ray? Now, you saw the guidelines. Nobody says we should have them. If you do them, and historically we did, a lot of abnormalities were discovered, and anywhere from 10 to 23% of patients had something, that they were asymptomatic, it was an incidental finding. Did it influence management? Very infrequently. Was it predictable from the H&P? Maybe. Importantly, though, who follows up on this? So we're talking about the 0.5 centimeter, 1 centimeter nodule, non-calcified in the left lower lung that is discovered. If you are doing the pre-op and you are the patient's primary provider, you will follow up on it, and that's okay. That takes care of it. But very frequently, this isn't your patient. It's your partner's, and they didn't have time on their calendar, so you're filling in, or it's just somebody else's patient. And then how do you convey that information, and who does the follow-up? And I can tell you, this is just a huge opportunity for things to fall through the cracks. Some of the stuff won't need much follow-up, but some will. And this is why, one reason why we don't recommend chest x-rays preoperatively on a routine basis. I had a colleague, he's now retired, a thoracic surgeon, very nice fellow, but an older guy now, and he said he built his career as a young surgeon taking out benign nodules from patients who had findings on preoperative chest x-rays. Now, albumin I mentioned because you may read about it. It is indeed a powerful predictor of perioperative complications, particularly pulmonary complications, infectious issues, wound healing, and it can predict morbidity and mortality both. Now, the reason that I'm mentioning this is that I have never ordered an albumin as a pre-op test. And you should be able to predict if the patient's albumin might be low just on the basis of your history and exam. Now, if they have, nephrosis or cirrhosis or protein losing enteropathy or something like that, you ought to know that. And you can predictably say, well, their albumin is low, so they're probably at higher risk for some of these other things, but you don't really have to check the albumin. If you think it would modify things, go ahead, but I can't think of a situation where that might be the case. How about the glucose? Now, in a non-diabetic patient, there really is no reason to do it unless you're trying to rationalize it by saying, oh, this patient never comes in, they have risk factors, they're obese, there's a family history of diabetes, and the current guidelines say that's the kind of patient we should screen. So we're doing other blood work, let's throw on the glucose. And I really can't argue with that, but from a purely preoperative standpoint, there isn't a great reason to do it. Now, will it change your management? If they're a new diabetic and they're totally out of control, it would, but that's infrequently the case because, again, they should be having some symptoms that you would pick up on. But if they are diabetic, is there a reason to check their status? And in this case, it's more the hemoglobin A1C than a glucose, because sometimes it does result, I should say, in a delay of surgery. And this is particularly the case for orthopedic surgeons. Many of them won't do, for example, a knee replacement or any kind of arthroplasty if the hemoglobin A1C is over 8. So you should probably measure the A1C, at least if you don't have one that's within a couple of months in that setting. Liver function tests, and we talked about this before. If there's a suspicion of liver disease on the history or exam or previous liver function abnormality, then you need to do the combination of things to do the MELD score, and we discussed that when we went through that case. How about pregnancy testing, our last case? These are 2 studies, pretty good size, where they subjected every woman of childbearing age to a pregnancy test. And the first study before elective ambulatory surgery, and then the second elective orthopedic surgery. Now, the incidence of pregnancy in women who didn't know they were pregnant was very low, 0.3% and 0.2%. And as you see, it costs a little bit to test everybody. The second study is more because it's a little bit more recent. But the patients tended to cancel their surgery if they knew they were pregnant. Now, whether they had to or not, I think is up to debate, but, it's the patient's decision. And if it's an elective operation, I think their rationale is why subject, the baby to something that they don't need to be subjected to, about which there may be some questions. So the Anesthesiology Society says that the literature is inadequate to inform patients about harmful effects. You can offer it to female patients of childbearing age and for whom it would result in management change. Well, if the patient says, I don't want to have the operation, that's a management change. So I think that there's a reason to do it. And there's enough uncertainty about this that, and enough, litigation about pregnancies that go wrong, that I think it's better to err on the side of doing the pregnancy test. The British, they have their National Health Service mandate that they want consensual blanket testing of all women of childbearing age for pregnancy. They don't actually do it in a blanket way, but that's what they recommend. And I guess this came out of some concern a few years back now, because England had a very high rate of adolescent pregnancy, and they didn't feel that the adolescents were always giving a reliable history about their risk of pregnancy. My children are well beyond adolescence, but there may be some truth to that. I don't know. You'll have to make up your mind. Pulmonary function testing. What about PFTs pre-op? If a lung resection is being done, you should do pulmonary function testing. Otherwise, they don't influence management. You need to make sure that patients with underlying pulmonary disease are on their full regimen of inhalers, and that they're using them correctly and whatever else they're taking. But you don't have to do pre-op pulmonary functions unless, again, there's a lung resection. And what you're looking for, if it is a lobectomy, is an FEV1 of over 1.5 liters and over 2 liters for a pneumonectomy. And these are actually calculations done by the radiologist based on a CT. Now, we don't see these patients too often. They're usually followed by the pulmonary folks. And so we don't have to make these decisions. But the point of this is that the patient with COPD or asthma who is clinically well or clinically stable, you don't have to repeat their pulmonary function test. Now, if they come in for the pre-op exam and they are not stable, we'll say a COPD patient who may be having an exacerbation or bronchitis or perhaps a pneumonia, you may want to do some pulmonary function testing, and depending on their exam, a chest x-ray. And you may need to ask the surgeon to delay the surgery because you want them maximally compensated before they go to the operating room. So you call the surgeon and the surgeon says, great, you take care of it and we'll just bump this out to next week. And your answer should be, talk to me next week and we'll see how the patient's doing, because they may or may not be ready to go next week. They're ready to go when they're completely back to baseline. COVID testing. Now, this is a difficult slide to read, so I'm going to try and walk you through it. And this was from, now about 1.5 years ago. On the left side, we have time from COVID diagnosis. And on the right side, we have risk of MACE, which is major adverse cardiac events. And we have a low risk category and an elevated risk. So time from diagnosis, asymptomatic mild COVID, if it's less than 7 weeks, low or high cardiac risk, you delay surgery. If it's over 7 weeks and they're low risk, you can proceed. If they're high risk, only if they really have to proceed. I mean, you really go with some caution. Now, if they have severe disease and it's been less than 7 weeks since the diagnosis, you delay and delay. If it is over 7 weeks, but they're still symptomatic, you still delay in all cases. And if it's over 7 weeks and they are not symptomatic, you can proceed if they are low risk and not, or at least cautiously only if they are at higher risk. So the key thing here is 7 weeks. But this was a study released just about 1 year ago. And it was based on the timing post-COVID from the UK. Again, so they have a large number of patients from the National Health Service databases. And they looked at patients operated on between March of 2018 and March of 2022. Now, there weren't that many procedures percentage-wise that were done in less than 7 weeks, but 3% of a big number is a large number. After the availability of vaccines was wide, The mortality was 1.1% if surgery was done within 2 weeks of diagnosis and 0.3% if within 4 weeks. So what this suggests is that in asymptomatic patients, if the surgery is urgent, for example, a new malignancy, something like that, it may be safe to perform in less than 7 weeks. So routine pre-op testing should be dictated by you and your exam. A couple of extra points quickly. Everybody that you see should be screened for OSA. Now, if they have OSA, you don't need to screen them. You need to tell them to bring their CPAP machine or whatever they're doing to the hospital. And even if it's an outpatient procedure, if something changes and it's then switched to an inpatient procedure, or they're transferred to an inpatient facility, they should have their CPAP with them. There are many ways to screen. Stop bang questionnaire is probably the most commonly used, but untreated or unrecognized OSA can cause problems. And if you encounter a patient like that, so they're undiagnosed, you do a stop bang and they have a high risk of OSA, and their wife says, yeah, he's snoring all night long. You're not going to necessarily start them on CPAP pre-op, but you need to prominently document that this patient may have OSA and certainly is at risk for some problems, so that anesthesia can arrange for some oximetry post-op. They might put the patient in the ICU post-op, or they might move an outpatient procedure to an inpatient procedure. Medicines. Blood pressure medicines. We typically hold diuretics, certainly loop diuretics. Thiazides, you can kind of go either way, particularly if it's a very short outpatient procedure. But if it's a longer inpatient procedure, I would hold even the thiazides. These patients are NPO, they're going to be getting IV fluids, there may be fluid shifts, so I think it's best to hold them. Now, you should also consider holding ACEs and ARBs. And the reason for this, and there's still some controversy about this, but the reason is that patients who take an ACE or an ARB the morning of surgery tend to have an exaggerated drop in their systolic blood pressure with the induction of anesthesia. Normally, there is a drop in your blood pressure with anesthesia induction, but if there is an ACE on board or an ARB on board, it's a bigger drop. So it might be 30, 40, 50 millimeters. So the way I handle this personally is that if the patient, when I'm seeing them, has a blood pressure on the high side, they're 140, 50, 60, I may say go ahead and take the ACE or ARB. But if they're lower at baseline, well controlled, 110, 120, 30, I will ask them to hold it. Now, this applies only to the morning dose. If they are taking something in the evening, they can take it. But you want to avoid hypotension, and certainly anesthesia wants you to avoid hypotension. Diabetes. PO meds in general should be held. Certainly metformin should be held if they're on a sulfonylurea, an older class of drugs, they should be held. Pretty much anything PO. They're going to be managed with insulin post-operatively if they stay in the hospital. They're not going to be getting any of these other drugs. Ultra long-acting insulin, so Lantus, can be given at its full dose the night before surgery. And most of the time it's taken at night. Now, I'll tell you a caveat here. Ask the patient what their normal or what their usual first morning blood glucose is. If they say, well, it's 140 or 50, go ahead and give them the entire dose of their Lantus. They should be just fine. If they say, well, it's 90 and sometimes less, I would then cut the Lantus in half, 50%. Most of the time, though, you can get by with the full dose of the ultra long actings. Intermediate insulins, NPH, you cut by 50% the day of surgery. So if the patient takes 25 units, they should take 12, 12 and a half the morning of surgery. You don't want them to have no insulin, because then their glucose is really going to be high and difficult to manage. What about the newer drugs? The SGLT2 inhibitors, these are the sodium glucose transfer inhibitors, should be held 3 to 4 days pre-op. 3 to 4 days. These drugs need to be completely out of the patient's system. And the reason is they are prone to developing a normal glycemic ketoacidosis. So we now have the patient who is NPO, getting IV fluid. The risk of that is quite high in the perioperative setting. So they just simply have to be out of the equation. How about the glucagon receptor agonists? The first drugs are the flozins, empagliflozin. These are the tides, semaglutide, and so forth. They should be held, and this again is a little controversial, they should be held the day of surgery if it's an oral formulation, or the week of surgery if it's injected weekly. Now, the rationale for this, or the reason for this, is based on the fact that, as you all know, these drugs delay gastric emptying, and that's the mechanism of weight loss when used as that, for that. But you don't want delayed gastric emptying if you're going to be using general anesthesia, or any anesthesia for that matter. So there is a theoretical risk, and there are case reports of, actual increased aspirations. Now, that said, just last week, there was a research letter published, I believe in JAMA, it could have been in JAMA Surgery, that said they retrospectively looked at a large group, of patients who had emergency surgery, and they all had these drugs on board, and they didn't see an increased risk or an increased incidence of aspiration. So maybe you don't have to hold them. I personally would hold them. If there's a question about something like this, where, the patient does aspirate, they have pneumonia, they're on a ventilator, this is not something you want to put the patient at risk for. So I guess I would hold them. As I said, the diabetes is going to be managed with insulin in the immediate perioperative period, and the presence or absence of these drugs shouldn't make too much difference. Beta blockers and other cardiac meds should be continued. Anticonvulsants should definitely be continued. You don't want the patient to wake up and have a seizure. Pain meds should be continued. Now, there's often a question about buprenorphine. Buprenorphine at high dose is pretty difficult to manage postoperatively in terms of pain. The pain is, not the drug. It is best to have the patient on 16 milligrams total per day or less pre-op. So if they're on a very high dose, you may want to try and taper them down if you can pre-op, and use other medicines to augment the pain issues if they're having pain issues. The other thing that you have to consider is buprenorphine is often combined with naloxone, and that's mainly to prevent other drug use in the setting of opioid use disorder. The naloxone is going to be a problem if you're trying to give morphine or something like that in the hospital. So if they are on that combination, you need to get them on straight buprenorphine ahead of time. Parkinson meds should be continued. Again, the patient's NPO, they don't get their meds, it's time to get out of bed and they can't move. MAO inhibitors can be given, and all inhalers should be continued. And even patients who are on just a rescue inhaler, for example, mild exercise-induced asthma, I tell them to take the inhaler the morning of surgery, because there is some bronchoconstriction that anesthesia induction can cause. So these are some excellent summary references if you want to do more reading. They'll be on the slides that you get. And we are ready for questions. So I thank you for your time this morning. And if you have questions, I'm happy to answer them.
Yeah, thank you so much, Dr. Lohr. And if anyone has any questions, please feel free to submit them into the chat, the Q&A, or raise your hand and I will unmute you.
We're not seeing hands, don't be shy.
Yeah, please feel free. Oh, we have our first question. Is there any type of template?
Any type of template for, I'm not sure I understand the question. Maybe they should raise their, or unmute the person.
Oh, yeah, here we go.
Jonna, what do you mean by any kind of template?
Yeah, so the question is there any kind of a checklist? Because normally these are all mixed in, obviously, with our, day-to-day visits, physicals,
Right.
follow-up visits. It's a busy day, as you know, and it can be easy to miss something. We use a template, but I know some of these things that we want to check on prior to sort of doing the consultation are in it, but I just wonder if there's any kind of published, maybe a checklist of sorts to say, okay, if this person's on specific types of blood pressure medications, we should be paying attention to, diuretics specifically, maybe ACEs and ARBs, and the diabetes meds. Do you have anything like that, or you just kind of work by memory because you've done it for so long?
I'm not aware of a published template like that. It actually would be a good thing to have, although it'd be something you'd have to probably update every 6 months or a year. But I'm not aware of one like that. I think, so yes, it's mostly memory. It's a good question though. And as I said, or as you said, you're doing this in the middle of a day with lots of other things going on. So this stuff may not be, top of mind all the time. I think the main thing that I would actually use, I'm going to have to back up a long ways here, is somewhere here. These, 5 or 6 things. Have you considered their cardiac status, their pulmonary status, the drugs, and then you're going to have to remember, their NPO, the diuretics, and so forth. Make sure you're asking about bleeding, clotting disorders. Make sure you tell them how to manage their diabetes, and then make sure you've addressed the possibility of other conditions. If you kind of do these 5 or 6 things, you're going to cover the bases. Now, there are a couple of other questions that you should also be asking in terms of drugs. Are they on steroids, prednisone? Because those patients may or may not, depending on the dose and the duration, need supplementation of the steroid. And their smoking history and alcohol history are both important, particularly the alcohol history. Patients who go through alcohol withdrawal postoperatively it's stormy, let me put it that way. So you do need to ask about their alcohol consumption. And when I ask them and they say, well, I drink socially, I really pin them down. I want to know how much they drink and how often they drink, because social drinking can mean all kinds of things. So I think if you think about these things and then maybe throw in a couple of other, write in a couple of other things, you will cover the bases pretty adequately. Okay. Any
Thank
other
you.
questions?
The next question is, what is the effect of marijuana?
I don't believe that there is any adverse effect other than the fact that it's if it's inhaled. What's that? Well, anyway, if you're smoking marijuana and it's inhaled, obviously it can cause some lung problems. If the patient is a very, very heavy marijuana user and some daily, multiple times daily, for whatever reason, and you stop it altogether, they may have some withdrawal, and that may have to be supplemented with, I wouldn't have them smoking marijuana in the hospital, but some oral combination of things. So if it depends on their use. If it's an occasional use, I wouldn't worry about it at all. If it's chronic and it's a lot, then I might have some concern about withdrawal. And again, it's not something you would be doing, in your pre-op exam, but rather mentioning it so that the people in the hospital know that this may be an issue for them to deal with.
Thank you. Are there any other questions? Going once, going twice. All right, well, if there are no other questions, thank you so much for your talk today, Dr. Lohr.
All right, thank you very much for your time. And well, there are some questions up here, or maybe they're not questions, but there's other chats. Is that right?
So just thank you for your expertise. Thank you. This was very helpful. Just some really kind words in the chat. And I
Oh.
want another one. Thank you so much.
We'll take all of that. Anyway, thank you for your time, and we'll see each other again in a couple of weeks.
Yeah, absolutely. Have a great day, everybody.
Okay, bye-bye.